Hello and welcome back to Data with Duke, the show where we take all things data, boil them gently for 20 minutes, season with sarcasm, and serve up piping hot insights that even your nan could understand. And to those who've noticed, I've been away for a few weeks. I'm absolutely right. I've been ill. I mean, proper ill. Like the sort of ill where even your dog looks at you and is like, mate, pull yourself together. So I've actually spent about a fortnight, 3 weeks experiencing the biological equivalent of a Windows 95 error screen. And I thought, let's do an episode about health data, the good, the bad, and the embarrassingly optimistic. So that's what I'm going to be talking about today. Now, I actually prepared for this podcast weeks and weeks ago, but then Christmas happened, which obviously takes a lot of planning and alcohol. There was, I got around to New Year's and I thought, actually, I really do need to start recording that. So, actually, while I was thinking about that, I am going to do another episode next week, probably, or the week after, about New Year's resolutions. So I'd love to hear about your New Year's resolutions. We'll talk about some on the next show as and when we record it. Put your comments on. Let us know. Contact us through the website, datawithduke.com, whatever you want to do. That's what's coming up. But I'm going to go back and do the health data one, because that's what I prepared for, and I'm still not 100%. I'm not going to lie. But listen, let's talk about it. So today we're talking about how data is used in health in the UK and around the world. We're going to cover some pretty heroic success stories, some catastrophic failures, but we're also going to talk about Google's brave but dodgy attempt at becoming Dr. House. That's right, Google Flu Trends is back, baby. So grab your lemsip, buckle up, and let's talk about times when data has actually saved lives, and also the times where it quietly ruined somebody's afternoon. So, the first thing that we're going to talk about is basically the basics of health data, and in other words, why doctors love spreadsheets as much as symptoms even. So, let's talk about health data. Health data is everywhere. If data had a Tinder profile, the NHS alone would be swiping right so fast it would get carpal tunnel. So I'm going to talk about things like electronic health records and hospital episode statistics and public health surveillance. I'll come on to genomic sequencing and wearables and the Fitbit you bought in 2019 and haven't charged since, a little bit later on as well. But it's important to really talk about that in the UK, the NHS, for those of you who aren't aware, is one of the world's largest, slightly creaky, semi-magical data system. There's about 1 million people use the NHS services maybe every 36 hours, and every appointment, every prescription, every x-ray, every emergency room I accidentally swallowed a keyring story becomes more data. Globally, health data actually helps governments identify disease outbreaks, plan vaccination programs, predict winter pressures, and work out whether Karen's symptoms mean she's allergic to gluten or just needs to drink some water and stop Googling things at 3 a.m. But the big story, the one that really defined what happens when data gets above its station, is Google Flu Trends. And oh boy, it's a beauty. So the story of Google Flu Trends has been going on a little while ago. I'm going to give you an introduction on this podcast today, but I am going to put some links of some blogs and some information, some research papers about Google Flu Trends on the show notes, datawithduke.com. Go and have a look for it. There's a lot of information. If you're into that sort of thing and you'd like to understand a little bit more about big data, and how big data can work really, really well, this is one of the best case studies that you can come from. So, Google Flu Trends, big data meets big oopsie. We need to go back in time a little bit. Picture the year 2008. Barack Obama has just been elected. Everyone's wearing oversized belts. Google decides it wants to predict flu outbreaks using search data. So cast your mind back. This is before ChatGPT. This is before Gemini. This was even before the autocomplete that comes up on Google search. More on that later. Just a simple search. You go onto google.com and you would type in whatever the search is. And the idea being is that Google would start looking at things like people Googling flu symptoms. Or why do I feel like death? Or how long can a human survive on lemsip alone? And maybe, just maybe, if they have a look at all of those searches in a particular region, they can identify that there's a flu outbreak going on. So Google basically built Google Flu Trends, GFT that I'll call it, based on that concept. And it was a model that basically looked at search patterns and used them to estimate flu prevalence faster than traditional surveillance systems. So go back a little while ago, a little bit before 2008, the only way really that we could identify if there was a flu pandemic starting was for the doctors to actually report it, the GPs to report it, the pharmacies to report it, somebody somewhere in a central health board to sort of start looking at that, to speak to other people in another health board who would then maybe go to local or central government and say, oh, we might actually have a flu pandemic going on right now. And of course, by the time that happened, most people had got the flu and most people had actually got over it. So Google's idea was actually quite genius. They thought, if we can identify daily in a particular region how many people are likely to have the flu based on their search behavior, then we're going to get them much, much quicker. For a while, it actually worked. So between 2008 and 2011, GFT actually tracked flu trends surprisingly well, usually quicker than the CDC, the US Centers for Disease Control. Everyone clapped. Headlines declared big data will replace epidemiologists. Somewhere 1,000 statistic professors sighed into their coffee. GFT was a shiny new toy of digital epidemiology. But then, like most shiny toys, it got dropped down the stairs. So around 2012, going into 2013, GFT started massively overestimating flu cases. And I mean really badly, as in some cases, double or even more than double the actual prevalence. So some research has happened ever since, and why did this happen? Well, quite obviously, search behavior does not equal illness. People Google weird stuff. Sometimes they do it out of concern, sometimes because someone coughed on the bus and they want to make sure they're not dying, or sometimes because WebMD has convinced them that they have 15 minutes to live. So searches didn't really always correlate with real infections. So I've done a previous episode where I've spoken about correlation and causation, and this is a perfect example. People Google stuff doesn't necessarily mean that they actually have an infection. Another part of it, another problem of it, and this bit always makes me laugh, is that Google changed the way that the search algorithms work. Yeah, the model broke, GFT broke because Google updated itself. So in 2012, Google actually expanded the autocomplete and the personalized suggestions. So suddenly typing, "why is my nose?" you're getting might autocomplete to things like running flu symptoms, you're probably dying quick, click here for some remedies. So I'm just going to take a pause here for a minute, because if you've never done this, this is absolutely genius. And if you want some time to waste on a Sunday afternoon trying to motivate yourself to record maybe the next podcast, I don't know, it's always quite fun just to jump onto google.com and just type in a couple of words into search and see what happens on autocomplete. If you're really feeling adventurous, I would always recommend, just to get a few laughs or maybe a few sort of "I've never gone on the internet again" moments, type in "why is my girlfriend" or "why is my boyfriend" and just see what comes up on autocomplete. Now, that autocomplete that we've got used to now in 2026, I should say, that we've actually got used to, didn't exist until 2012. So when people started searching for things that might sound something like flu symptom, if Google thought, wait a minute, I'm expecting a flu symptom search here, it would start auto-completing it and people would be clicking on it because they'd be like, oh, that sounds interesting, let me click on it. Doesn't mean they've got the flu, they might not have any symptoms at all. But Google has said, oh, you might want to look at this, and there you go. This is what's happened. So that's what Google did. It's very useful. It's very funny. But actually, it caused the search volumes for flu symptoms to spike artificially. The problem is that GFT didn't know that Google had changed its behavior. It just assumed that flu had gone nuclear. As a result of the autocomplete and more people actually using Google for lots of different things, Google were feeding an enormous amount of data into the algorithm and basically saying, I don't know, you figure it out. And this is often where big data can go wrong. Correlations can actually appear accidentally. And in one of the examples that is quite highly cited, but when you go and look at those blogs that I read when I was preparing for this, one of the actual highest correlations, incorrect correlations, was identified. If somebody searched for high school basketball, Google flu trends assumed that they had the flu. The reason for it was because basketball season overlaps with winter. GFT didn't know that, and it actually linked that basketball was giving people the flu. Another problem was that the model just simply wasn't updated enough, and Google have actually said that, they, don't get me wrong, they invested a decent amount, a ridiculous amount of money into this project. But actually, it was quite a small drop in a large ocean, and they just simply didn't have the budget to update it as often as perhaps they should have. An analogy, if you'll forgive me, is that big data is almost like milk. It's great when it's fresh, but after a few weeks, it gets really, really tragic. GFT simply wasn't retrained quickly enough, so the errors accumulated almost like mold on cheese. So in 2013, in the flu season, I should say, of 2013, GFT actually overestimated the peak flu cases by over 140%. So something that was originally the poster child of big data is going to save the world, then became the poster child of data hubris. The idea that big data can solve everything if we just gather enough of it, spoiler alert, no it can't. So Google shuts it down, quietly, like a sad goldfish. Basically, in 2015, Google Flu Trends was very quietly discontinued. There was no dramatic blog post titled, "We messed up badly, sorry." They just stopped updating the public tool and moved on with their lives, leaving data scientists to point at it forever as the perfect case study as to why correlation does not equal causation. Correlation does not equal meaning or insight. So why is this important? Why does this matter? Why am I talking about this? Because GFT taught us that big data cannot replace traditional public health systems, and that search behavior, what people search for, is not only heavily influenced by platform design, hence the autocomplete that Google introduced, but it's also influenced by media. I'm recording this on the 3rd of January, and I'm pretty sure that Stranger Things is going to be quite high on the search results at the moment. Without even looking, I could guess that. If somebody was to go and look at those trends in 5-10 years' time, they're probably not going to understand within context actually what that search was all about. The media does influence search quite a lot. Machine learning models is another thing. Machine learning models will break if the platform that is generating the inputs changes. And then also, if your model is essentially guessing based on autocomplete, maybe don't bet your entire epidemiology strategy on it. I mean, still, as failures go, it's certainly one of the most educational and strangely a lovable one. Data scientists, universities nowadays are still talking about it many years on, about how big data can be used positively and the downsides of it as well. But anyway, that's Google Flu Trends. I want to talk a little bit about stuff that goes on in the UK, because not everything is on fire. Sometimes there are wins, actually more often there can be wins than there are losses when it comes to health data. So I want to talk. Just don't turn me off yet. Don't pause yet. I want to talk about the UK's COVID-19 response. We're specifically going to be talking about the data. So before you groan, don't worry. We focus on the data side. I'm not going to be talking about political chaos or that image that's been ingrained into most people's minds of politicians on the screen telling us to sing happy birthday when we're washing our hands or that sort of thing. I want to specifically talk about the data. Because actually, surprisingly, during the COVID pandemic, the UK became a global leader in a number of different data areas. And one of them was actually genomic sequencing. So the UK sequenced more SARS-CoV-2 samples, so that's sort of like the type of virus that COVID-19 fell under, than almost any other country in the world quite early on when the pandemic started. And what that meant is that the UK, and therefore we're able to share it with the world, identified variants like the alpha and the beta and the omega sort of variants far earlier than many nations. So it was the UK, for example, that highlighted that there were different variants of the COVID virus that were coming out with different symptoms for people. Another thing that the UK did is the COVID dashboard, the beloved color-coded national obsession. There was a COVID dashboard that was actually developed inside the UK, and it became one of the most comprehensive public pandemic data portals in the world. It was updated daily with how many cases there'd been, how many hospitalizations there'd been, how many vaccinations had been administered, how many deaths there had been. It was able to break it down regionally as well. I'm not going to sit here and say that it was amazing. It wasn't perfect, but it did set a standard for something that actually needed to gather data quickly, process that data quickly, and publish it out to the world on a daily basis. Was actually it was not a small feat. Not perfect, but still a pretty good example of how things can be done. And then the last thing is to talk about the recovery trial. So, run by Oxford, the recovery trial was one of the fastest and largest clinical trials in history. And it used data-driven adaptive trial designs, and they were able to identify lots of different things about different medication and things like that. So apologies if I mispronounce any of these. I've spent 5 years trying to say lansoprazole correctly. But here we go. Dexamethasone was actually contributed to reducing mortality rates. Hydroxychloroquine doesn't work, despite what certain political leaders were saying. Azithromycin also doesn't help, despite what other political leaders were saying. And then this other one that I'm probably butchering the name of, but tocilizumab actually improved outcomes in some cases as well. And this sort of data that was created or generated or gathered, or the insight that was gathered from the data run by Oxford as part of their huge clinical trial. Doesn't matter which way you think about it, this data saved lives. They saved thousands of lives, in fact, worldwide. And this is all the UK. The UK actually contributed a huge amount towards that. So it's worth highlighting, really, that, don't get me wrong, I'm not going to sit here and say that the whole thing was handled perfectly well. But from a data point of view, the UK's response to COVID-19 compared to the rest of the world was actually, evidentially, considerably far ahead of other countries in the world. Anyway, moving on from that, we'll talk about wearables and remote let's try this. Wearables and remote monitoring as well. So how many of you have got a Google Watch or a Fitbit or an Apple Watch or a Samsung Watch or something similar to that? Apple Watch were the first to introduce heart rhythm notifications. This is something that's become quite universal now, but somebody who's actually very close to me first discovered that they were experiencing heart arrhythmia because their Apple Watch told them. Even people who have type 1 or type 2 diabetes are able to monitor their glucose in real time, basically, and make adjustments to their diet and their food as a result of the information that they were giving. People who have respiratory issues can have blood oxygen sensors that is feeding directly into sometimes into medical teams, or even sometimes into equipment to say, oh, we need more oxygen or less oxygen or something like that. One of the things that I've actually benefited from is sleep tracking. My watch that I wear to bed most nights tells me how I have slept, and I've been able to make decisions about what I should be doing that day, actually based on how much recovery sleep that I've had. All of these devices, they produce real-time data. And again, it's not perfect. I'm not going to say that they should replace your doctor. And in fact, what I would suggest is that your doctors can use this data to identify early warning signs. In other words, does your watch know your heart rate better than you do? Oh, absolutely. Does it also occasionally panic because you walked up the stairs too fast? Also, yes. So wearables probably going to be the future in gathering health data again in the future, and I'm confident in saying that we're going to see a lot more advancements in that sort of area. But it's still not perfect yet. But it's a downside further forward than we were even just 5 years ago. Another thing to talk about is genetics and personalized medicine. I don't know if you've done one of these ancestry things or genome link or however many there are. There, 23andMe, I think, was another one. I can't remember the names of all of them. All started, of course, for the Genomes Project that started in the UK. They show how sequencing in the Genomes Project, sequencing could be used to identify hereditary characteristics that can lead into diagnosing rare diseases years earlier than even symptoms show. Outside of the UK, in Iceland, Decode has been used in population genomics for about 2 decades or so to study hereditary disease risk. Iceland, for those who are unaware, as small as a country it is actually quite high on the list as having a population that lives longer and healthier as well. I'm not going to say that this is all down to data and science. Of course, there's going to be a lot to do with exercise and diet as well, but it's got to help, right? And then the last one to talk about is wastewater surveillance. And listen, stick with me because it sounds gross, okay, but it's absolute quite genius. So countries like the US and the Netherlands and Australia are actually using wastewater data, and they're analyzing wastewater to track levels of things like COVID and flu and RSV and even norovirus and polio. That's right, your toilet flush is now a public health instrument, and no, you cannot opt out. So that's quite interesting. So those are some of the success stories. Keep an eye on the future podcasts, I guess, and the news to see where this goes. But of course, I'm not going to sit here and say that this is fantastic. Sometimes it goes wrong. I spoke about Google Flu Trends earlier. There's a couple of other examples where it hasn't gone wrong that I think are important to talk about. So in the UK, going back to about 2013 or so, there was a plan to actually link GP records with hospital data to help support research. So you may or may not be aware of this if you're in the UK, that if you go to see the GP and they refer you to a hospital department, your GP does not have intrinsic automatic right to anything that goes on within that hospital department. Your GP either has to request it or it needs to be specifically, with permission, handed over from the hospital to your GP. There are laws within the UK, actually based upon the EU's GDPR, that would prevent such a thing from being shared without your express permission. So the plan was, actually, this is causing a bit of a bottleneck with our data. If our hospitals and our GPs can't talk, and we can actually research how things are going on, then this is causing a bit of a bottleneck. So let's remove that bottleneck. And it sounds great, right? But the NHS didn't really explain that they were doing it to anyone at all. And then when people started figuring out, wait a minute, data is being shared between these different health organizations, people panicked about privacy, and the government, rightly or wrongly, decided to pull the project because of the privacy concerns. The moral of that little story, actually, is that if you surprise the British public with anything, even good healthcare, they will absolutely revolt. We will. The next one to talk about is IBM Watson. So I think this is genius because IBM have had a tool called Dr. Watson for a long, long time. They created basically an AI tool that they called Watson that was going to help diagnose cancer. It was an oncology tool. But it turns out that even though it was trained quite well, Watson ended up giving quite unsafe or actually sometimes incorrect recommendations in some test cases. Doctors eventually quietly asked it to leave the room. And then the final one to talk about where things can go wrong, and I think this is probably the most relevant, really, is that algorithmic bias is something that can creep into any data analysis or machine learning or AI model. And there are many healthcare algorithms that have been found to underestimate disease risk within minority groups. For example, let me give you an example. So there are certain diseases that may actually go unnoticed within people with black heritage or African heritage, and it's just simply down to a slight change in physiology. But the problem is that because the UK were basing their data sets on a sample of the population that didn't accurately represent the amount of black people or people of black descent or heritage that we have within the UK, that basically led to the data that we were using being biased. And the consequences of this can actually be quite severe. You can underdiagnose people. You can produce incorrect prioritizations and systemic inequalities. And the thing is, this links so closely into the whole idea of ethics, the ethics of health data. I'm only really going to touch on that because that's a huge conversation by itself. But let me just explain it this way. Let me explain this sort of situation. Let's go with the example of diseases that are more prevalent or more deadly for people of black heritage. But it was based upon, it wasn't discovered because the research, the machine learning model was based upon a sample that had mostly white people in there. So let's just say that some important health decisions were made, health strategies were created as a result of this biased model, and what that led to is more black people dying. Can you imagine what would happen? Just imagine for a second if that actually happened, what the fallout for that would be. So when I say the algorithmic bias, when it's one of those things that people sort of say, the machine got it wrong, maybe we'll try again. No. It can be very, very serious and very, very deadly in some cases. So a very important thing to consider. Anyway, let's move on away from that. The final sort of thing that I want to talk about really is that why am I talking about this today? Why is health data so valuable, and actually also why it's so messy? Health data is quite simply gold dust. For want of a better analogy, really, it's almost like the golden, low-hanging apple off the orchard of data, because it's personal. Health data is personal. It's also very predictive. It can be used. Health data can be used to reduce healthcare system costs. It can support clinical research. It can improve service planning for. It's been in the news quite recently about, again, we're in flu season. Lots of people go into the hospital. The hospital is under strain as a result of that. But if we had that health data, they can plan a little bit better for it. I'm not going to say they're going to take away all of the strain, but some of it, surely. The problem with health data, of course, is that it can be, and it is, very fragmented. The data that I have in my watch, my doctor doesn't see that unless I show it to them. The hospital will also not see that unless the GP, I have given the GP the permission to show it to them. So that fragmentation can actually cause some problems. The inconsistency in the approach that falls off the back of that, as well as other inconsistencies, can cause problems as well. One of the things to consider is that technology has improved so much over the last 5-10 years or so, that a lot of the data that we actually have on health has been locked away in outdated methods of recording or even outdated systems. There are systems that exist within the NHS at the moment. There are very few people left in the country able to actually read it or use it or program it. It's also, as I touched upon earlier, when I talked about disease risk within minority groups, and I used the example of black patients, that it's ethically sensitive. It's incredibly ethically sensitive. There are groups of people that rightly enough, want to be treated the same as everybody else. But physiology and health tells us that actually there does need to be differences in how people are treated based on characteristics that they hold within their DNA. But actually approaching that can be quite tricky from an ethics standpoint. Another thing about health data is that it is quite prone to missing values. I told you earlier that I wear my watch to bed some nights and it tells me how I slept. I don't wear it every night, and therefore I'm missing that sleep data. Multiply that by 100 million, billion, trillion, and we're quite close to how many missing values we can have in health data. And another thing that's important to highlight is that some of the health data that we actually have stored on the NHS systems has been entered by tired doctors at 4 a.m. in the morning after a double shift in an emergency room. Health data can be the dream data set. It is often the nightmare data set. Not perfect, but people are still plugging away at it. People still think that there's gold to be found that can answer a lot of questions, that can improve everybody's quality of life. So, lessons that we've probably learned, hopefully, I should probably say learned, from health data over the last 15, 20 years or so. Everything from Google flu trends to COVID dashboards. But what we know is that big data is very, very powerful. but it's also very, very messy. And actually, how you're getting your data, the input of your data, is a very important concept. Search behavior is not the same as clinical data. Another thing we've learned is that transparency matters. People, the public, they want to know how their health data is actually being used. And if you don't tell them, or at least you don't make that information transparent and available, then some people are not going to like it. It's important to highlight that even though the data can do a lot, traditional medicine, traditional epidemiology is still essential and it still matters. Models, machine learning models, AI models should support public health systems and not replace them. And when you do have these models, keep them up to date, please. If your world changes and your model doesn't, you're basically predicting the future using last year's horoscope. And then finally, ethics. It's not optional. Health data is deeply, deeply personal. And apply that to your general public, the millions of people that live just in the UK. The public has to trust how the data is going to be used by the NHS before the NHS should be using it. And that applies worldwide as well. So in conclusion, no, data isn't medicine, but it can and has saved lives. So health is one area where data genuinely makes the world better. We've used it to detect outbreaks, save lives, discover treatments, understand diseases we didn't even have names for a few years ago. But we've also learned that technology companies aren't public health agencies, and being able to count search queries doesn't make you Dr. Gregory House. As for me, I'm feeling pretty much better. Mostly what I needed was rest, some fluids, and definitely avoiding WebMD at all costs. So listen, thanks for tuning in to Data with Duke. Stay safe, stay curious, and if you feel ill, don't Google it. Call somebody with actual medical training. This is Duke, signing off.